Metformin is a widely used anti-diabetic drug that was approved by the FDA in 1994 for the treatment of type 2 diabetes, and it is available in both immediate release and extended release formulations, often being used alone or in combination with other anti-diabetic agents. Now, when a patient is newly diagnosed with type 2 diabetes, the first step usually involves lifestyle modifications such as improving diet and increasing physical activity. However, when these measures are not sufficient to control blood glucose levels, metformin is typically introduced either as monotherapy or as part of combination therapy. In fact, according to the American Diabetes Association, metformin is the preferred first-line drug for both adults and children aged 10 years and older. Furthermore, treatment decisions are often guided by HbA1c levels at diagnosis. For instance, if HbA1c is less than 9% and there are no major comorbid conditions such as cardiovascular disease, heart failure, or chronic kidney disease, metformin monotherapy is usually recommended. Whereas if HbA1c is greater than 9%, metformin is started along with other medications. It is important to note, however, that metformin is not used in type 1 diabetes. In addition to its primary indication, metformin also has several off-label uses. For example, it is used in the management of gestational diabetes, helps address weight gain associated with antipsychotic medications, and plays a role in both the prevention and treatment of polycystic ovary syndrome. Moreover, it is currently the only anti-diabetic drug recommended by the ADA for use in prediabetes. Beyond these established roles, ongoing research is exploring its potential benefits in areas such as anti-aging, anti-cancer effects, and neuroprotection, thereby highlighting its expanding clinical relevance. When we discuss the mechanism of action of metformin, it's important to understand that it does not act at a single site. Rather, it works through multiple organs and its effects vary depending on the clinical context. Now remember that metformin is a hydrophilic or water-loving molecule, and therefore it cannot easily cross the lipid-rich cell membrane on its own. As a result, it depends on specialized transporter proteins to move in and out of cells. These include organic cation transporter 1 or OCT1 plays a major role in the liver by allowing metformin to enter hepatocytes. Similarly, OCT2, located in the kidneys, helps move metformin from the blood into renal cells, thereby preparing it for elimination. In addition, OCT3, which is more widely distributed, including in the intestine, contributes to drug absorption and distribution throughout the body. On the other hand, transporters like multi-drug and toxin extrusion proteins work in the opposite direction by pumping metformin out of cells, especially into urine for excretion. Therefore, overall, metformin's entire journey from absorption to action and finally excretion is tightly dependent on these transporters. Moving forward, the most clinically significant action of metformin occurs in the liver, where it primarily reduces blood glucose by inhibiting hepatic gluconeogenesis. As a result, there is a decrease in endogenous glucose production without increasing insulin levels, which is a major advantage. Moreover, it is important to understand that gluconeogenesis is a major source of liver glucose, and it becomes especially active during fasting. Furthermore, in patients with chronic type 2 diabetes, this process is even more exaggerated and often poorly regulated. As a result, the liver continues to release excess glucose into the bloodstream, thereby worsening hyperglycemia. Therefore, when a drug like metformin suppresses gluconeogenesis, it directly targets this core problem. Consequently, hepatic glucose production decreases and blood glucose levels begin to improve. At the cellular level, metformin was traditionally thought to act mainly on the mitochondria, where it was believed to transiently inhibit complex 1 of the electron transport chain, thereby reducing the cell's energy levels and consequently reduce glucose production. However, more recent evidence challenges this idea, since the concentration needed to inhibit complex 1 is much higher. But this concentration is not achieved during routine clinical use of metformin. This is further supported by experiments in which a known complex 1 inhibitor, pyridine, was infused into rat livers. However, despite effectively inhibiting complex 1, they observed that hepatic gluconeogenesis was not suppressed. In other words, the liver continued to produce glucose even when complex 1 was blocked. Consequently, this finding suggests that simply inhibiting complex 1 is not sufficient to explain the glucose-lowering effect of metformin. Nevertheless, what consistently emerges is that metformin creates a low-energy state within the cell, not by completely shutting down mitochondria, but rather by mildly reducing mitochondrial efficiency and thereby slightly decreasing ATP production through multiple mechanisms. Under normal situation, when the cell is in a high energy state, ATP is continuously being used for cellular work in the cytoplasm, and therefore ATP is normally converted into ADP as it releases energy. Now, this ADP does not just stay there. Instead, it is transported into the mitochondria. Once inside, ADP is converted back into ATP by ATP synthase during oxidative phosphorylation. So under the influence of metformin, ATP production in the mitochondria slightly decreases. It means ATP is being used up and getting converted into ADP. As a result, ADP begins to accumulate. Now to compensate for this, the enzyme adenylate kinase, which is present in the cytoplasm, comes into action and converts two ADP molecules into one ATP and one AMP. Therefore, although a small amount of ATP is regenerated, AMP is produced as a byproduct, and as a result, AMP levels increase. In addition to this, metformin further amplifies this effect by inhibiting AMP deaminase, an enzyme that normally breaks down AMP in the cytoplasm. Consequently, AMP accumulates even more. So putting it all together, in a high energy state, ATP is abundant and AMP remains low. Whereas in a low energy state, decreased ATP production in the mitochondria leads to increased ADP and subsequently increased AMP in the cytoplasm. And this rise in AMP becomes a key signal that drives important metabolic changes in the cell. In normal situation, especially during fasting when glucagon levels are high, in this state, glucagon binds to its receptor on hepatocytes and activates a G protein pathway, which in turn stimulates adenylate cyclase located on the cell membrane. This enzyme then converts ATP into cyclic AMP inside the cytoplasm. And as cyclic AMP levels rise, it activates protein kinase A. Consequently, pKa triggers a cascade of events that increase gluconeogenesis, meaning the liver produces and releases more glucose into the blood during fasting. However, when metformin increases intracellular AMP levels, this changes the situation significantly. Elevated AMP directly inhibits adenylate cyclase, and therefore the conversion of ATP to cyclic AMP is reduced. As a result, intracellular cyclic AMP levels fall, and consequently, protein kinase A activity decreases. Because of this, the entire glucagon signaling pathway becomes weaker, and the liver is no longer strongly stimulated to produce glucose. Therefore, gluconeogenesis is suppressed. So metformin increases intracellular AMP levels, which in turn lowers cyclic AMP levels and consequently reduces hepatic glucose output. In addition, metformin activates AMP activated protein kinase (AMPK), which functions as a cellular energy sensor. Under normal conditions, when ATP, that is energy, is sufficient, AMPK remains mostly inactive because the cell doesn't need to conserve or generate extra energy. However, when metformin increases AMP levels, this signals that the cell is running low on energy and therefore AMPK gets activated. Now, once AMPK is turned on, it immediately tries to restore energy balance, and it does this in two coordinated ways. First, it switches on catabolic pathways, meaning processes that generate ATP. For example, it increases glucose uptake into cells and enhances fatty acid oxidation. So the cell starts producing more energy. At the same time, it switches off anabolic pathways, which are energy consuming processes, as cells are already low on energy. For instance, it inhibits fatty acid synthesis, cholesterol synthesis, and protein synthesis, all of which require ATP. So clinically, AMPK activation reduces hepatic gluconeogenesis and increases glucose uptake in muscle, and therefore lowers blood glucose without increasing insulin levels. That's exactly why metformin is first line. It improves glycemic control while also addressing insulin resistance. Secondly, in conditions like fatty liver, AMPK inhibits fatty acid synthesis and promotes fatty acid oxidation. As a result, fat accumulation in the liver decreases, which can improve liver function and slow disease progression. In addition, activation of AMPK increases glucose uptake into cells and therefore improves insulin resistance and overall insulin sensitivity in peripheral tissues. Consequently, it is particularly useful in metabolic conditions such as prediabetes and metabolic syndrome, where insulin resistance is the core problem. There's also emerging relevance in polycystic ovary syndrome, where improving insulin resistance through AMPK activation can help regulate ovulation and metabolic abnormalities. Additionally, metformin may slightly reduce intestinal glucose absorption, but this is a minor contributing mechanism. So this is the overall mechanism of metformin action. Now the administration. Metformin is administered orally and is widely used in the treatment of type 2 diabetes, with total daily doses typically ranging from 500 to 2550 milligrams. However, to minimize gastrointestinal side effects, it is advised to take the medication with meals. In clinical practice, metformin is available in two formulations, immediate release and extended release, and the choice between them depends on patient convenience and tolerability. For the immediate release form, treatment is usually initiated at 500 milligrams once or twice daily, or 850 milligrams once daily, and then gradually increased on a weekly basis in increments of 500 or 850 milligrams to reduce GI intolerance, with a typical maintenance dose of around 850 to 1000 milligrams twice daily. Similarly, for the extended release formulation, therapy generally begins with 500 milligrams or 1000 milligrams once daily, followed by gradual titration in 500 milligram increments over several weeks, up to a maximum of about 2000 milligrams per day, which may be given once or in divided doses. Furthermore, the extended release form is preferably taken once daily with the evening meal and should be swallowed whole with a full glass of water, while in general, patients are encouraged to take metformin consistently at the same time each day to maintain stable drug levels. Overall, Metformin remains an effective, safe, and affordable medication. And importantly, it has also been associated with a reduction in cardiovascular events and mortality, as supported by current clinical guidelines. In addition to its primary role in the treatment of type 2 diabetes, metformin is also used off label for the prevention of type 2 diabetes, particularly in individuals at high risk, such as those with prediabetes. In such cases, therapy is usually started at a low dose, commonly 500 milligrams once daily, and then gradually increased based on tolerance and clinical response. However, some guidelines also suggest starting with 850 milligrams once daily, which may be increased to twice daily if needed. Thus, with careful dose titration and patient-specific adjustment, metformin can help delay or prevent the progression to overt type 2 diabetes. Another important off-label use of metformin is in the management of antipsychotic-induced weight gain, which is a common metabolic side effect seen in patients receiving certain psychiatric medications. In such cases, metformin helps improve insulin sensitivity and reduce weight gain over time. However, as with other indications, dosing is introduced gradually to improve tolerability. For the immediate release formulation, treatment is typically initiated at a lower dose and then titrated to a range of about 750 milligrams to 2000 milligrams per day, usually given in 2 to 3 divided doses, while in some studies, doses up to 2550 milligrams daily have been used. Similarly, for the extended release formulation, therapy usually begins with 500 milligrams once daily, and the dose is then increased in increments of 500 milligrams every 2 to 6 weeks, depending on patient tolerance, up to a typical maximum of 1000 to 2000 milligrams per day. Another important off-label use of metformin is in the management of gestational diabetes, where it can help achieve adequate glycemic control during pregnancy. In such cases, treatment is usually initiated with the immediate release formulation at a low dose of 500 milligrams once or twice daily. However, to improve effectiveness while maintaining tolerability, the dose is gradually increased over time to a total of around 2000 to 2500 milligrams per day, typically given in 2 to 3 divided doses. Furthermore, if target blood glucose levels are not achieved with metformin alone, insulin therapy may be added alongside it to ensure optimal control. Another important off-label use of metformin is in the treatment of oligomenorrhea associated with polycystic ovary syndrome, where it helps improve insulin resistance and thereby supports the restoration of normal menstrual cycles. In such cases, therapy is usually initiated with the immediate release formulation at a low dose of 500 milligrams once or twice daily. However, to enhance tolerability and reduce gastrointestinal side effects, the dose is gradually increased on a weekly basis in increments of 500 milligrams. In addition to its indications and off-label uses, it is equally important to consider specific patient populations when prescribing metformin. First of all, in patients with renal impairment, dosage adjustment is guided by regular assessment of renal function. For instance, no dose modification is required when eGFR is above 60 milliliters per minute and routine annual monitoring is sufficient. Whereas for eGFR between 45 and 60 milliliters per minute, no adjustment is needed, but more frequent monitoring every 3 to 6 months is recommended. However, when eGFR falls between 30 and 45 milliliters per minute, initiation of metformin is generally not advised, although some clinicians may cautiously use low doses such as 500 milligrams daily. Importantly, metformin is contraindicated when eGFR is below 30 milliliters per minute due to the risk of lactic acidosis. Furthermore, in patients with hepatic impairment, metformin is typically avoided because of an increased risk of lactic acidosis. In addition, Special considerations apply in pregnancy and breastfeeding. Although metformin was previously categorized as a relatively safe drug in pregnancy, insulin remains the preferred treatment for gestational diabetes according to current guidelines. While metformin may be considered in cases where insulin use is not feasible. Similarly, metformin is excreted in breast milk, but metformin is considered compatible with breastfeeding because only a very small amount reaches the baby, and that amount is generally safe. Moreover, in pediatric patients, metformin is not recommended for children below 10 years of age, whereas in older adults, it is advisable to start with lower doses and titrate cautiously, given the higher likelihood of reduced renal function. Therefore, careful patient-specific evaluation and monitoring are essential to ensure both the safety and effectiveness of metformin therapy. Metformin is generally considered a safe and well-tolerated medication. However, like all drugs, it is associated with certain adverse effects that should be understood in clinical practice. Most commonly, patients experience gastrointestinal symptoms such as diarrhea, nausea, and vomiting, which can occur in up to 30% of cases, especially during the initial phase of therapy. Therefore, gradual dose titration and taking the drug with meals can help improve tolerability. In addition, although less frequent, some patients may report symptoms such as headache, chest discomfort, sweating, weakness, hypoglycemia, or rhinitis. Furthermore, with long-term use, metformin has been associated with reduced vitamin B12 levels, and consequently, patients, particularly those presenting with anemia or peripheral neuropathy, should be monitored and supplementation may be required when necessary. Importantly, metformin carries a black box warning for lactic acidosis, which, although rare, is a serious and potentially life-threatening condition. This occurs due to the accumulation of lactate in the body, leading to metabolic acidosis, and may present with non-specific symptoms such as malaise, respiratory distress, and an increased anion gap. Moreover, certain risk factors such as renal or hepatic impairment, advanced age, hypoxia, surgery, and excessive alcohol intake can increase the likelihood of this complication by either impairing lactate clearance or lowering blood pH. Therefore, patients should be advised to avoid excessive alcohol consumption while on metformin. In addition to adverse effects, drug interactions must also be considered, as some medications can increase the risk of lactic acidosis, including agents like bupropion, cimetidine, iodinated contrast media, and others, while certain drugs such as salicylates, SSRIs, quinolones, and other anti-diabetic agents may enhance the glucose-lowering effect of metformin and increase the risk of hypoglycemia. Therefore, careful monitoring and appropriate dose adjustments are essential when metformin is used alongside other medications to ensure both safety and effectiveness. In addition to its adverse effects, it is equally important to understand the contraindications of metformin to ensure safe use. First and foremost, metformin is contraindicated in patients with severe renal impairment, particularly when the eGFR is less than 30, as this significantly increases the risk of lactic acidosis. Furthermore, metformin must not be used in patients with known hypersensitivity to the drug or in those with metabolic acidosis. In clinical practice, it is also recommended to temporarily discontinue metformin on the day of surgery and in situations such as dehydration, nausea, or vomiting, where the risk of lactic acidosis may increase. Moreover, metformin should generally be avoided in patients with significant hepatic impairment or unstable heart failure, as these conditions can impair lactate clearance and increase the risk of serious complications.